And here is your question. Yes, now. All right. If you have read and understood, considering its surgical pathology station, kindly tell me what is the provisional diagnosis that you will consider for this patient?
So maybe the patient have a pancreatic mass, could be gastrinoma.
Okay. And?
Differential could be insulinoma.
Yes. What are the group of conditions that are?
It could be MEN, multiple endocrine neoplasia.
Yes. All right. If you can define the term hyperplasia.
So hyperplasia is increase the number of cells in an organ or a tissue.
Yes.
Response for any stimulus.
Okay. So in as a whole, how many parathyroid glands are there which can be affected?
Four parathyroid gland. Yeah, 4 glands can be affected.
Yes. Okay. Can you tell me the microscopic picture of hyperplasia, or if you take a specimen of this patient in slide, what would you see?
Okay, so for this patient, histologically we can see chief cell hyperplasia,
Yes.
which may involve one or multiple gland in multinodular pattern or diffuse pattern. And then we can see some oxyphil cell. And
yes.
That one is called what? Is water clear cell hyperplasia.
Yes. What is the island of oxyphil cells? These are originated or found from where?
I don't know.
Okay. Right. Can you tell me, you also gave a differential diagnosis, insulinoma. So what clinical picture can a patient present with?
So the patient may come with confusion, stupor, then loss of consciousness, maybe falling down and sweating.
What would be the blood glucose level?
So blood glucose level might be less than 2.5 millimole per liter.
Okay.
Or even less.
Millimole per liter. All right. And what else? How would you confirm your diagnosis for this particular patient? What investigations would you ask for?
We can do some blood test. We have to look for insulin level in the serum. So if it's less than 10 micro unit per ml, and we have to look for insulin to glucose ratio. If it's high, then we can think about insulinoma. And of course, we can do imaging. We can do CT scan abdomen or MRI abdomen. Is there any tumor in the islets of Langerhans or pancreas?
What are the biochemical tests that can be done to confirm this diagnosis? If you can mention few.
Yes, biochemical test we can do like serum glucose. Then we can do high level of insulin.
Okay.
We can do insulin to glucose ratio.
Yes.
And insulin resistant test.
Okay. Can you tell me what other pathology would you suspect if a patient is suffering from MEN1 syndrome?
Okay, so we can suspect it could be a pituitary adenoma or it could
Yes.
be a parathyroid adenoma.
So what are the gene mutations that you suspect in case of insulinoma?
Okay, so here the gene will be PTEN and THC.
And
These two I can recall.
okay, there is another one as well. So 3 gene mutations take place in case of MEN1. So right, how would you differentiate MEN1 syndrome from MEN2 syndrome?
So MEN2, it will be mostly this this pituitary, then parathyroid, and plus it will be adrenal gland will be involved, like pheochromocytoma, and then it can be medullary thyroid carcinoma also can be there. And type 2B, it will be all the feature of MEN2A plus Marfan habitus.
If I ask you to define the term apoptosis, how would you define it?
So apoptosis is a programmed cell death which doesn't require energy, and it can kill the cell mostly in physiological condition.
Okay. Right. You told me, can you tell the clinical features which can a patient with MEN2 syndrome be associated with?
So for MEN2, maybe if the patient is having a medullary thyroid cancer, he or she might come with an anterior neck mass, thyroid mass. And then if the patient is having pheochromocytoma, then maybe the clinical feature will be abdominal pain, hypertension.
In case of MEN2 syndrome, which oncogene mutation takes place?
I forgot that one.
RET, proto-oncogene.
That,
RET.
okay.
Okay, can you please tell me if MEN2 syndrome, what kind of mode of inheritance MEN2 syndrome has?
MEN2, I think, is autosomal dominant, I think.
Very good. Yes, don't think you are confirmed. All right, if
Okay.
you can tell me what would you like to exclude when it comes to operate a patient with MEN2 syndrome? If you have
So
to
we have
operate
to-
on a patient, yes, with MEN2 syndrome, what would you like to conclude or rule out before you operate on?
So we have to rule out the patient might have a pheochromocytoma.
Very good.
So we
Very
have
good.
to rule out does he or she have it or not.
Yes. So what would you do? What investigations
Okay,
would
so
you
we
do
can
to
do
confirm it?
some blood test, we can do some imaging, and
Yes.
some urine test. So in blood test, we have to look for serum metanephrine catecholamine,
Yes.
and then we have to look for urine 24 hours VMA,
Yes.
vinylene mandelic acid, then
Yes.
24 hours catecholamine as well. And then we can do some imaging, ultrasound, CT scan, or maybe MRI.
Right. So
And
what
if it's confirmed, then we can do maybe PET, CT scan.
Very good. So what management can be offered to the patients suffering from MEN syndrome?
So for management, if the patient is having a medullary thyroid cancer, we have to do thyroidectomy and then send for biopsy. If there is any positive lymph node, we have to do lymph node dissection. And then if there is a pheochromocytoma, that one also we can do either a open laparotomy or maybe laparoscopic removal of the tumor.
Okay, good. Thank you. Bell went.